Thank you, the organizers. Bismillah ar-Rahman ar-Rahim. Alhamdulillah. Salatu salam ala Rasulillah. We are going to make an interactive. I will not talk too much. So many videos you will see, and together we'll see what's happening. So as an introduction, whenever we try to diagnose a seizure, the first level is to see what seizure type we have. Is it focal onset? Is it generalized onset? Or if you don't witness, you say unknown onset. Then you try to see the etiology. Structural, genetic, infectious, metabolic, immune, or unknown. After that, you try to see what type of epilepsy you have. Again, is it focal, generalized, combined, or unknown? And then try as much as possible to alienate an epilepsy syndrome. So, and there are many comorbidities associated with epilepsy. So there are many epilepsy syndromes. We are not going, of course, through all of them. Many of them are benign, and many of them are encephalopathies. In International League Against Epilepsy Classification 2017, they classified the seizure types as follows: focal onset, generalized onset, unknown, and now they changed from, nobody's using now loss of consciousness, they're using aware or impaired awareness, and then you see the motor onset or non-motor onset. The same in the generalized and the unknown onset. Terms which are not any more used: complex partial, simple partial, psychic, dyscognitive, secondary generalized tonic seizure are not anymore used. So the first case scenario, the patient is a third child of parents who are healthy, first cousins. She was born by normal delivery. Birth weight, hair circumference, everything is normal. Apgar score normal. And the mother had only history of 2 miscarriages. She was discharged from the hospital in a good condition on the second day after delivery, but readmitted into Tom Hospital, where I worked a few years ago, on the third day because she manifested 3 cyanotic spells with apnea and clonic movements of the upper extremities, every 10 minutes lasting between 1 and 2 minutes each. During the first day of admission, she manifested 4th attack, witnessed by the nurse, and this attack involved clonic movements of upper limbs and associated with apnea and cyanosis for 1 minute. The attack ceased spontaneously. Clinically, the patient demonstrated no abnormal facial features, vital signs normal, all basic laboratory tests, including cerebrospinal fluid normal, cranial ultrasound and MRI, as well as interictal EEGs were normal. Then the patient developed repeated right side clonic seizures every few days, beginning the second day after discharge at the age of 8 days, for a total of 7 attacks with a maximum duration of 2 minutes in the first 3 weeks after discharge. 4 months later, again, she developed a left-sided focal tonic clonic seizure, and the final 2 seizures were prolonged multifocal clonic seizures lasting 5 to 10 minutes, respectively. The parents refused any anti-epileptic treatment, and the infant was monitored and followed up to the age of 3 years with no any seizures and normal motor and cognitive development. This is the family history. There are many patients with many other family members with seizure. For example, the father developed seizure at the age of 7 months. An older sibling has no seizure but had delayed speech. And the second sibling, 4 years of age, history of 3 seizures. And 3 maternal cousins, currently 8 and 12 and 21, has history of repeated seizures. So we did genetic testing, which showed direct DNA sequencing, potassium channel Q2 gene of the proband and of her family, a deletion of the adenine nucleotide in the exon 9 that is a cause of frame shift in the protein. This is classified as a pathogenic variant, and this mutation has not been previously described. So now from this, what is the diagnosis? So you have a baby. He started to have seizures early in his life. 3rd day, these seizures are repetitive. Some of them are prolonged. And there's a family history. And then you did the mutation. So what your, yeah? Okay, benign. Neonatal, because of the neonate. Familial, because of the family. No need for focal, because we might have focal generalized. Epilepsy. So now nobody's mentioning benign, nobody's mentioning self-limited neonatal familial epilepsy. And we published this with other colleagues when I've been in Tawam Hospital. Okay, we'll go to the second one. Now, a few words about self-limited neonatal seizures. The syndrome typically onset of between 4 and 7 days. In the past was called 5th day seizure. In children are born prematurely, the seizure may occur within days of being at term by corrected age. Seizure remit by 4-6 months of age, the majority ceasing by 6 weeks of age, and both sexes are affected equally. Everything is normal, pregnancy, head size, neurological examination, and also the development. And some neonates have KCNQ2 mutation, may have also myokemia. Okay, we'll go to the second scenario. This is a 2-year-old boy developed these hemoclonic seizures with facial twitching.
Do you see your lips going blue?
If you see some hemifacial, and there is clonic seizures, especially on the left side. Twitching of the face, and clonic seizures on the left arm. Because of the time, we'll go. So this patient was normal vertex delivery. First seizures were febrile seizures. Since the age of 8 months, started to have afebrile focal, tonic-clonic, resistant to anti-epileptic drugs, normal development up to 1 year of age, and then plateauing later on. And the age of 16 months started to have truncal ataxia, and at the age of 18 months started to have atypical absence seizures and myoclonic seizures. Neurological exam at the age of 2 years showed spasticity of the lower limbs and positive Babinski sign. All basic laboratory tests normal, including CSF. EEG was normal initially, but later on the second year it showed generalized spike and wave and multifocal discharges. And it is photic stimulation precipitated generalized spike and wave discharges. And it was enhanced by sleep deprivation and sleep. MRI basically normal. So we did genetic testing, which showed SCN1A gene, sodium voltage gated channel alpha subunit 1 mutation at chromosome 2. So what's your diagnosis? It's very easy again. This is an infant who has a mutation, and the seizures are prolonged and difficult to treat, and started with febrile seizures, usually focal febrile seizers, and hemifocal usually. So, any clues? Sorry? Okay, nearby, but usually the MRI normal. So this is Dravet syndrome. In the past, it's called severe myoclonic epilepsy of infancy because of the myoclonic seizures. But now they found that they may have other types of seizure, as in this child, may have absence seizure, atypical absence seizure, may have hemifocal tonic-clonic seizures. So, few words, this is Dravet syndrome. Charlotte Dravet with me a few years ago, described by her in 1978. Characterized by seizure typical around 6 months of age. Most had seizure onset less than 15 months of age. Everything is normal at the beginning. The first seizure associated with fever in about 60% of cases. Immunization may be a trigger. And head size, neurologic examination initially normal, but over time they develop ataxia and pyramidal signs, and the development usually regresses or plateaus later on. EEG by the second year of age becomes abnormal with generalized spike and wave discharges and multifocal discharges. And in 95% of cases, the mutation are de novo and 5% are inherited. We'll go to the third case. So this is a 15-month-old boy presenting with recurrent episodes of this unresponsiveness for last 2 weeks, 1 to 2 times per day, every 5 to 6 days, total of 10 episodes. This is a home video, and here I want to emphasize the importance of home video taken by the parents. So the baby is, or the child, is an infant, is looking to one side. This is non-motor. As we said, we can have motor or non-motor. This is non-motor, almost, very few movements. And Versailles, he's looking to the one side, up on one side. And it takes about 1 to 2 minutes and usually stops spontaneously. Born by normal vertex delivery at full term after an uneventful pregnancy. Everything is normal. Apgar score is normal. And this is the family pedigree, which shows that the father had the same problem when he was the same age. And there's some 2 cousins here have something called paroxysmal kinesogenic choreoathetosis. And there's family history also of febrile seizures. Exam, lab EEG, everything is normal. Basic laboratory test normal. MRI normal. And clinically is normal, and neurologically is normal. And we did the genetic testing, which showed the proline-rich transmembrane protein 2 mutation. So what is the diagnosis again? Very simple. You have an infant, so infantile. You have familial, and it is benign because everything is normal. Now it's called self-limited, but let's say benign, infantile, familial, epilepsy. Very simple. So self-limited or benign, familial, infantile epilepsy. Of course, you have the non-familial, which when you don't find the gene. As we said, the gene usually is de novo mutation. And we published this many years ago in Saudi Arabia, the first series in the Middle East, and 14 cases of benign familial, non-familial infantile seizures, which I gave them the name of Fukuyama Watanabe Vijayabane syndrome. Fukuyama was my professor, late professor, died a few years ago. And Vijayabane is the Italian doctor who delineated the genes, and Watanabe is before him in Japan. The first case, 1 year, 1 month old infant, developed mild diarrhea with vomiting, with low-grade fever. The next day, the infant developed, sorry, this is my loud voice, cluster of focal seizures, 3 attacks with 10 minutes interval, each 1-2 minutes, which were aborted spontaneous and normal development. And again, there is no, it is non-motor. The child is only looking to one side. What we call now impairment of awareness. You don't say loss of consciousness. And this is also a video taken by the parents. Clinically, the patient demonstrated no abnormal facial features, normal skin power tone and reflexes, vital signs normal, basic laboratory tests including cerebrospinal fluid normal, MRI done normal, and repeated interictal EEGs normal. Stool analysis showed rotavirus positive and no bacterial growth. So what is the diagnosis? Again, very simple. You have an infant with a mild gastroenteritis, which did not affect his electrolyte imbalance, and it is benign because the development is normal. So again, benign infantile seizures with mild gastroenteritis, associated with mild gastroenteritis. So benign infantile seizures associated with mild gastroenteritis. This is a syndrome. This syndrome is delineated in Japan before, but now it's everywhere. And we published this a few years ago, again, electroclinical features of benign infantile seizures with mild gastroenteritis. Of course, you have to make differential diagnosis with febrile seizures and with non-febrile illnesses seizures. Few words about benign infantile seizures associated with mild gastroenteritis, characterized by the following criteria: occurrence in infants aged between 4 to 30 months, infants with normal psychomotor development and neurological examination. Seizures may be focal or generalized. Usually, the seizures are brief, repetitive, and in clusters, and can be isolated. There is associated mild gastroenteritis with low-grade fever or absent fever, and not associated, is very important, with any electrolyte derangement or hypoglycemia, with normal CSF to rule any infection, normal interictal EEG, and normal brain imaging. And of course, a benign course. You have to follow this patient to see if it is a benign course or not. The fifth scenario, Emirati girl with no significant pre or postnatal history, normal motor and cognitive development, presented to our pediatric neurology clinic at the age of 5 years, 3 months, with history of 4 attacks of screaming while asleep. The first seizure occurred at the age of 4 years and 4 months of age. At that time, she developed recurrent, this is very important, retching and vomiting, and eyes turned to one side, and she then became flaccid like a rag doll with minimal motor activity for 2-3 minutes, and following that was partially unresponsive for about 30 minutes, so very prolonged. The second and third attacks occurred 2 and 4 months later, respectively, with similar semiology and lasting for 1-2 minutes. And the fourth attack occurred 2 weeks before the patient presented to us, during which versive seizures with eyes deviation to one side continued again for about 30 minutes. This is the family pedigree. Examination, everything is normal. Clinically, she is normal. And this, can you click on that, please? Her EEG. Can you click on this one? No, click on the... Did you click? No, click on that one which I showed you. Sorry. Can you go back? Yeah. 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 I have to show you from here, sorry. Why is it not showing here?
This one.
But it's not showing there.
It's coming here, this one. Message.
It's not showing there? Okay, no problem. It's coming, okay. No need for the video. Can I press?
Yeah, sure.
It's not coming. Anyhow, I just want to show you that this child, whenever she closes her eyes, there is discharges. Unfortunately, the video is not showing here. If you see, there are many discharges whenever the child closes her eyes. Here, when she closes eyes closed, discharges. Here, no discharges. Here, discharges whenever close the eyes. Whenever eyes are open, no discharge, and so on. So what's the diagnosis? Sorry? Very good. Excellent. Sorry? Yeah. Can I have a clap for him, please? Because this is very difficult. So this is Paniatopoulos syndrome. Before it was called early onset occipital lobe epilepsy. It is the most important characteristic of Paniatopoulos syndrome, that prolonged seizure with autonomic manifestations. Autonomic mean everything, mydriasis, sweating, urination, but the most important thing is what is called ictus emeticus, with vomiting. The patient comes vomiting all the time. 50% of the cases, there is no convulsions, there is no apparent seizures. only when the child developed this deviation of eyes. I will show you one. Can you, next please? Next. Can you click on that one? Hopefully it will work. Yeah, so the child is vomiting. Can you enlarge, please? Yeah. Vomiting. And then you see there is deviation of eyes to one side. Here, it will come now. Can you move the arrow? Now there is deviation if you see to the left side of eyes. Otherwise, you will see the child is only vomiting. See, this is a seizure now. This is a seizure. And now she off of it. No, still, yeah. Now off the seizure. And repeat, again she developed a seizure. And there is impairment of awareness, but she does not lose consciousness totally. There is now a seizure. She looking to one side. Okay, next please. Okay, we published this in, it's very interesting because this Panetopol syndrome and with something called fixation of sensitivity, which is very rare. And we developed in this patient also something called inverted fixation of sensitivity, the first case in the world. Okay, scenario 6. An 11-year-old Saudi female with child developed no abnormal behavior during sleep many times per day for less than 1 minute. Patient has been seen by sheikhs, traditional healers, and treated as jinn possession, عندها jinn, seen by psychiatrist and given antipsychotic treatment. Clinically, the patient demonstrated no abnormal facial features. Everything is normal, vitals, basic laboratory test, and MRI. Can you put the... So this is during my round. Can you put both of them? Very short, hyperkinetic. Finished. This second, please. Excuse me, second. So these are two different episodes, and very short. So we did the genetic testing, which showed the neuronal nicotinic acetylcholine receptor. So what is the diagnosis? Gene possession. So a child who, it is autosomal dominant, this mutation, autosomal dominant. And usually whenever the child sleeps, so nocturnal, and the EEG shows frontal, so it's frontal lobe epilepsy. It's called ADNFLE. Autosomal dominant nocturnal frontal lobe epilepsy. We don't have time. We'll go to the last, which I always see. What type of seizure here? Anybody? So this is my granddaughter when she was young, dancing. And next one. And then when she was grown up. This is when grown up. Thank you.
Questions? Any questions for Dr. Imad? If not, I would like to ask you one question, Doctor. You have shown a lot of cases where genetic diagnosis has been done. So in which cases in particular would you think of doing it, going beyond EEG?
Yeah, the history. Whenever you have a familial pedigree. So the history is very important. This is for the young doctors. Take the history, whether there's other seizures there, you have to dig. Sometimes the family might hide. So whenever you suspect there is a familial history, usually sometimes I'm sending to the geneticist also. We have here privilege with Dr. Ayman also with us. So whenever you have a positive family history, then you think about, of course you have to have a consideration of these things. As I told here, if it's a baby, is a neonate, and then everything is normal, so you think of benign self-limited things, then you think about these genes.
Yes, thank you. Any theory for why it is benign, self-limiting, especially in neonates, 5th day? Why does that happen?
Why? Because you're saying because most of them many of the neonatal seizures are where you find some structure, because you have to rule out. You have to rule out the structure, if there's an HIE, if there's an infection, you have any metabolic. If you don't find anything there, all these etiologies there, then you have to think of self-limited neonatal seizures or infantile seizure and so on.